Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 227 of our Pharmacotherapy MCQ series, which majors in infectious diseases. And the first question reads, TYK, a 66-year-old woman on 40 mg prednisolone per day for temporal arteritis was exposed to a confirmed case of influenza A H1N1 P. DM09. TYK also had hypertension, asthma and osteoarthritis, for which she took amlodipine, lisinopril, paracetamol and inhaled salmeterol. TYK had not yet received her seasonal influenza vaccination. TYK presented to her doctor 24 hours after the exposure, and a choice of prophylaxis with either oral oseltamivir or inhaled zanamivir was considered. So my question to you is, what side effect of zanamivir is TYK at risk of developing? Is it A. agitation, B. bronchospasm, C. cardiac arrhythmia, D. Guillain-Barré syndrome, or is it E. Reyes syndrome? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. bronchospasm. I will justify why. This is a recognized complication of zanamivir use in patients with a history of asthma. The CDC recommends that zanamivir is not used in patients with an underlying respiratory disease. Public Health England do not have the same restriction. Please advance to the next question. And the next question reads, there was an outbreak of a viral respiratory illness on the bone marrow transplantation unit. 16 patients were affected, with varying degrees of upper and lower respiratory tract involvement. Transmission in the outpatient unit was implicated, with close contact and surface contamination important as routes of transmission rather than droplet spread. No healthcare workers were affected. One of the patients was a 59-year-old man who had received a matched unrelated donor allogeneic hematopoietic stem cell transplantation with non-myeloablative conditioning. 60 days after his bone marrow transplantation, he developed coryzal symptoms. Patient ASL deteriorated over 24 hours and developed symptoms of a lower respiratory tract infection, with cough, tachypnea, fever and hypoxia. ASL was admitted to a side room on the hematology ward. A chest radiograph was obtained which showed new pulmonary infiltrates. A nasopharyngeal aspirate was sent for respiratory virus PCR panel, microscopy and culture for bacteria, fungi and mycobacteria. A urine Legionella antigen was negative. A high-resolution CT scan of the chest showed small peribronchial nodules. These were non-cavitating, with a diameter less than 5 mm. So my question to you is, what is the most likely pathogen? Is it A. adenovirus 14, or B. human bocavirus 1? or C. influenza A H1N1, or D. parainfluenza 3, or is it E. SARS coronavirus? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. parainfluenza 3. I will clarify why. Parainfluenza is one of the more common causes of respiratory viral infections in patients with hematologic malignancies, hematopoietic stem cell transplantation, or solid organ transplantation, and is associated with a high rate of progressive disease involving the lower airway and an increased mortality rate. Para-influenza viruses are transmitted by direct person-to-person contact through large respiratory droplets and contact with fomites contaminated with respiratory secretions. Respiratory precautions are not necessary, because the droplets are large and do not aerosolize. PIV can cause asymptomatic shedding, particularly among HSCT recipients, which may contribute to nosocomial spread. Risk factors in this patient for progressive disease include allogeneic bone marrow transplantation and reduced intensity conditioning. Lower airway involvement may be characterized by small peribronchial nodules on CT radiography. Please progress to the next question. And the next question reads, PEK, a 48-year-old Senegalese man was found to be HIV positive on routine screening with a fourth-generation combined P24A-GAB ELISA. A confirmatory test with a second-generation ELISA for IgG to differentiate between HIV-1 and HIV-2 infection detected HIV-2 antibodies. PEK was negative for HIV-1 antibodies and an HIV-1 RNA viral load was negative. An HIV-2 RNA viral load was sent to the reference laboratory. PEK's CD4 count was 458 cells per microliter, that is cubed. So my question is, what class of antiretrovirals is HIV-2 intrinsically resistant to? Is it to A. chemokine receptor 5 abbreviated as CCR5 antagonists, or B. integrase inhibitors, or C. non-nucleoside reverse transcriptase inhibitors, or D. nucleoside reverse transcriptase inhibitors, or is it to E. protease inhibitors? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. Non-nucleoside reverse transcriptase inhibitors. I will clarify why. The NNRTI binding pocket is structurally different in HIV-2, conferring innate resistance onto this class of drugs. They should not be used in the treatment of HIV-2. Please proceed to the next question. And the next question reads, ROL, a 33-year-old man attended the sexual health clinic following partner notification for gonorrhea. ROL was screened for rectal, urethral and pharyngeal gonorrhea and chlamydia, and had epidemiological treatment for gonorrhea with intramuscular ceftriaxone and oral azithromycin. Given ROL's high-risk sexual behavior, with over 30 partners in the preceding 3 months, unprotected insertive and receptive anal sex, participation in chemsex parties, he requested a point-of-care HIV test. This was positive, and a laboratory sample confirmed HIV and hepatitis C infection. CD4 count was 525 cells per microliter, that is cubed. HIV viral load 12,458 copies per milliliter. Treatment was recommended given ROL's co-infection status and as he wanted to reduce the risk of transmission to partners. A baseline HIV resistance screen was obtained prior to starting tenofovir, M-tricitabine, efavirenz marketed as Atripla. So my question to you is, what mutation in his resistance test would predict likely treatment failure with efavirenz? Would it be A, M41L, or B, K65R, or CN155H, or DY181C? Or would it be EM184V? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is DY181C. I will explain why. The reason is that amino acid substitutions such as K103N or Y181C prevent NNRTI's binding. Please proceed to the next question. And the next question reads, NOP, a 45-year-old nurse returned from voluntary work during an outbreak of Ebola virus in rural Guinea. NOP had been directly involved in caring for patients within the red zone, that is the isolation area, in an Ebola treatment unit. 4 days after her return, NOP self-isolated and contacted her local public health unit as she had developed a fever, severe frontal headache and a sore throat. Urine, serum and an EDTA sample were sent urgently to the reference laboratory for an extended VHF PCR panel. What type of virus is Ebola classified as? Is it A, alphavirus, or B, arenavirus, or C, bunyavirus, or D, filovirus, or is it as E, flavivirus? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D, filovirus. I will justify why. Ebola and Marburg are both filoviruses. They have a distinctive filamentous morphology under the electron microscope with a non-segmented, negative-stranded RNA genome. They have a lipid envelope derived from host cell plasma membrane. Please advance to the next question. And the next question reads, during an outbreak of West Nile virus abbreviated as WNV in late summer in northern Texas, TZY, a 44-year-old woman presented with a 4-day history of fever, headache, abdominal pain, myalgias and anorexia. TZY had attended the emergency department as she had noticed difficulty in walking and twitching of her thigh muscles in the preceding 24 hours. On examination, TZY had reduced power grade 3/5 in left hip flexion and knee extension, absent deep tendon reflexes in both lower limbs and widespread generalized fasciculations. Sensory examination was normal. Csf microscopy results were as follows. Total protein 0.55 grams per liter. The normal range is 0.15 to 0.45 grams per liter. Glucose 4.1 millimoles per liter. The normal range is 3.3 to 4.4 millimoles per liter. White cell count 0.34 times 10 power 9 per liter, with 70% polymorphs. CSF PCR panel shows HSV1 and 2, VZV, enterovirus, echovirus and West Nile virus negative. Acute serum West Nile virus IgM antibody positive. Convalescent serum shows significantly high titer of neutralizing antibodies to West Nile virus, that is 1 to 320. Her MRI spine shows ill-defined non-enhancing hyperintensity in the cervicothoracic cord. So my question to you is, what is the likelihood that TZY will recover strength to near baseline? Is it A, 5%, or B, 20%, or C, 35%? or D 75%, or is it E 95%? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C, 35%. I will clarify why. Among patients with acute flaccid paralysis, about 1/3 recover strength to near baseline, 1/3 have some improvement, and 1/3 have little or no improvement. Treatment of West Nile virus infection is supportive. Several investigated therapeutic approaches, including ribavirin, steroids, IVIG, and monoclonal antibodies, have failed to demonstrate efficacy. Please advance to the next question. And the next question reads, MMM, a 29-year-old intravenous drug user presented with a one-day history of severe dyspnea, fevers, myalgia, cough and hemoptysis. MMM had been treated in the community for 2 days with oral amoxicillin but had deteriorated. MMM was known to be hepatitis C positive, genotype 1A, and was on the waiting list for antiviral treatment. MMM had previously had a right leg above knee DVT, and was on treatment dose low molecular weight heparin in the community. MMM also took methadone, diazepam and multivitamins. On examination, MMM's temperature was 39.2 degrees Celsius. The heart rate was 140 beats per minute and the blood pressure 110 systolic 64 diastolic. MMM had a respiratory rate of 32 breaths per minute, an SaO2 of 92% on 15 liters of oxygen. MMM looked profoundly unwell. There were coarse crackles bilaterally in the bases and midzones. A critical care consult was requested and the patient was discussed with the infectious diseases team. Neutrophil count was 1.9 times 10 power 9 per liter. CRP was 352 mg per liter. The normal value is below 10. Viral throat swab respiratory virus PCR panel turned negative, including influenza A and B. Urinary Legionella antigen turned negative. An X-ray of chest showed multilobar infiltrates with small bilateral effusions. So my question to you is, what antimicrobial regimen would be most appropriate in MMM's clinical scenario? Would it be A. daptomycin, or B. flucloxacillin and clindamycin, or C. linezolid, clindamycin and rifampin, or D. trimethoprim sulfamethoxazole? Or would it be E. vancomycin and rifampin? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. linezolid, clindamycin and rifampin. I will clarify why. The suspicion here is of panton-valentine leukocidin Staphylococcus aureus necrotizing pneumonia. The efficacy of antibiotics in necrotizing pneumonia is affected by the requirement for penetration into necrotic tissue and activity within anaerobic conditions. Public Health England suggest an empiric combination of clindamycin, linezolid and rifampin to start with, plus consideration of intravenous immunoglobulin abbreviated as IVIG, and admission to a side room in intensive care. Please proceed to the next question. And the next question reads, GHR, a 23-year-old intravenous drug user presented with an infected injection site in his left groin. GHR was septic and required inotropes in addition to aggressive fluid resuscitation. The left groin was red, hot and had marked localized edema around a central necrotic lesion. GHR was taken to theater for a surgical debridement and then transferred to the intensive care unit. Gram stain of tissue showed gram-positive bacilli. So my question is, what microbiological features would support a diagnosis of Bacillus anthracis? Would it be A. negative catalase, or B. beta hemolysis, or C. alpha hemolysis, or D. motile at 25 degrees Celsius? Or would it be E. resistance to trimethoprim sulfamethoxazole? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is E. resistance to trimethoprim sulfamethoxazole. I will explain why. Bacillus anthracis is commonly susceptible to penicillins, tetracyclines, quinolones, vancomycin and clindamycin. It is however usually resistant to the cephalosporins and trimethoprim sulfamethoxazole. Please proceed to the next question. And the next question reads, DFO, a 22-year-old man attended clinic for review of a split skin graft to a full-thickness burn on his left calf. The doctor was concerned about infection as there was worsening exudate and pain, with 2 cm erythema around the edges. A wound swab was taken and the patient started on empirical flucloxacillin. His wound swab grew the following: 1. Staphylococcus aureus, sensitive to methicillin. 2. Streptococcus pyogenes. And 3. Gram-positive rod, identifying as Corynebacterium diphtheriae, awaiting confirmation. So my question to you is, what confirmatory test on organism 3 would substantially alter the management of this patient? Would it be A. bacitracin sensitivity, or B. modified ELIC test, or C. Nagler's reaction, or D. Quelling test, or would it be E. reverse CAMP test? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. modified ELIC test. I will explain why. The ELIC immunoprecipitation test confirms the production of diphtheria toxin. PCR tests are now also available to demonstrate presence of the diphtheria toxin genes. Diphtheria toxin production requires enhanced public health management of both the patient and the close contacts. Please proceed to the next question. And the next question reads, ILK, a 24-year-old primigravida, 32 plus 4/40 attended with a 1-day history of fever, chills, myalgia and malaise. The pregnancy had been uncomplicated to date. ILK had had all her childhood vaccinations on schedule, and had not been in contact with a rash illness in this pregnancy. ILK worked in an office. No other contacts were unwell. A single temperature measurement was 38.0 degrees Celsius, but otherwise there was no other abnormality. There was no meningism, no rash and no pharyngitis. Bedside urinalysis was negative. ILK was kept for 6 hours observation during which she was afebrile. ILK was discharged home with advice to seek help if her symptoms persisted. 3 days later, ILK's clinician was phoned by the microbiology laboratory with the following result: blood cultures grew gram-positive rods. So my question is, what are the possible consequences that should be taken into consideration? Is it A. congenital glaucoma, or B. hydrocephalus, or C. no increased risk of adverse outcome, or D. stillbirth, or is it E. thrombocytopenic purpura? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. stillbirth. I will clarify why. This is a case of maternal listeriosis. The risks of this in late pregnancy include death in utero, or premature delivery of an infected infant if the infection progresses untreated. The classic description is of a biphasic illness, in which the first phase is a nonspecific acute influenza-like illness. Blood cultures at this point are invaluable in providing an early diagnosis. If unnoticed or untreated, premature labor or death in utero may follow within 2 to 14 days of the acute presentation. This can be prevented by early antibiotic treatment. Please proceed to the next question. And the next question reads, UDAA 75-year-old man presented with severe left-sided atalgia, worse at night, extending into his temporomandibular joint. The pain was aggravated by chewing, and UDA's hearing was reduced on that side. There was a purulent discharge from the ear. UDA had type 2 diabetes mellitus, hypertension and end-stage renal disease requiring maintenance hemodialysis via a native fistula. UDA had been seen in the ENT outpatients department 3 months earlier with left otitis externa, and received routine oral suction and gentamicin hydrocortisone ear drops topically. On examination, UDA had a swollen erythematous external auditory canal on the left with purulent debris and underlying granulation tissue on the floor of the canal. The right side was normal in appearance. It was not possible to visualize the tympanic membrane. There was erythema extending anteriorly over the temporomandibular joint, and posteriorly over the left mastoid process. The bony prominences and soft tissues were tender on palpation. UDA had a left-sided lower motor neuronefacial nerve palsy, other cranial nerves were intact. So my question to you is, what is the most likely causative organism? Is it A. Aspergillus fumigatus, or B. Proteus mirabilis, or C. Pseudomonas aeruginosa, or D. Staphylococcus aureus, or is it E. Streptococcus agalactiae? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. Pseudomonas aeruginosa. I will explain why. This is a case of malignant, necrotizing otitis externa, which is an aggressive infection of the external auditory canal that may be fatal. The majority of cases are caused by Pseudomonas aeruginosa. Other organisms implicated less frequently include Staphylococcus aureus, Aspergillus fumigatus and Proteus mirabilis. Elderly people with diabetes mellitus are particularly at risk. As the infection progresses, it may spread to cause an osteomyelitis of the base of the skull and the temporomandibular joint. Please proceed to the next question. And the next question reads, DIA, a 32-year-old woman presented with a 7-day history of cramping abdominal pain and bloody diarrhea. DIA had opened her bowels over 15 times in the preceding 24 hours. There was fresh red blood mixed in with the stool. DIA had vomited once, and felt feverish. DIA's symptoms had not abated since their onset. She had returned from a family holiday with her partner and 3 children 2 days before onset. Nobody else was symptomatic. DIA had no past medical history of note. Her stool culture grew Campylobacter jejuni. In addition to fluid replacement therapy, what is the most appropriate management? Is it A. azithromycin, or B. ciprofloxacin, or C. metronidazole, or D. no antimicrobials needed? Or is it E. trimethoprim sulfamethoxazole? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. azithromycin. I will clarify why. This is the first choice antibiotic for Campylobacter enteritis, as resistance is low for macrolide antibiotics. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 228.